Good morning. This is Babak, Larian. We're doing another Q&A session for parotid and salivary gland issues. Hopefully I can answer some of the questions you guys have been having. Hopefully this will be helpful to you. So let's start with the first question. Angela Starr was asking, what is the pain level after a benign parotid tumor removal and for how long? Very good question, Angela. So let me turn this around and explain. There is a nerve. There's two nerves that are very important to parotid surgery, right? The first one is the facial nerve. The facial nerve comes out of the skull here, divides into two branches that go on to the lower lip, the muscles of the neck, upper lip, smile muscles, eye, and eyebrow. This nerve doesn't have sensation, right? This is just in charge of movement of the face. There's a second nerve, which we'll draw in blue here, which is very superficial, immediately under the skin, called the greater auricular nerve. And that nerve comes up this way and goes to the lower part of the ear and kind of a circular area where the surgery would be for the parotid. And when we do the surgery, we were trained, I was also trained, to cut this nerve. And most places do, so it causes numbness of this area. Actually, I personally don't like cutting normal structures. And so I usually find this nerve and dissect it and push it out of the way so that I can get to the parotid here and preserve it. By doing that, what happens is that when the person wakes up, because the nerve was stretched, that area around here is numb, which initially is a little bit awkward, but it actually is numb for pain from surgery. So the pain is not dramatic, and I'd say probably 50% of my patients only take Tylenol for pain. Another 50% we give them stronger pain medications like codeine or Vicodin or something like that for a short period of time, for a couple of days, and that does the job. So the pain is not tremendous, at least the way we do the surgery here, which is more minimally invasive approach to it, and not very, very aggressive in handling the tissue and so on. And the reason I said, let me flip this again, is that the traditional incision for, let's say, a tumor like that, a traditional incision is this, that goes all the way down in the neck, even further. Our incision starts right behind that little thing in front of the ear, goes in front of the earlobe, and then tucks in here. So our incision is altogether probably about an inch, less than an inch maybe even, from there curving around to that, while this incision is a few inches, like 3 inches, maybe even more. And so it's a very different thing, because you obviously are more invasive and cut more tissue, so the pain is more. And then obviously when you make your incision further down, that nerve doesn't cause numbness from this area on downwards and this area upwards. So a portion of the incision actually does experience pain and discomfort. So all of that matters in the recovery of the person. But the pain in generality is not severe at all, okay, fortunately. Angela is also asking, how long does a person need to take off work after benign tumor removal? Angela, when we do the surgery, generally people have, the first week you have to take off because you're recovering, you're going to feel tired, and your body's using all your resources for healing. So that first week, you generally fatigue easily. So definitely 1 week. Yeah. Second week, you're still going to have swelling that's fairly obvious. So if you are in a line of work where you're dealing with clients, then you may want to either have a schedule that doesn't involve you seeing clients, or take the week off. If on the other hand, you're not dealing with people where the swelling is going to be an issue, you're just doing computer work, office work, or something like that, or you're just with your colleague and no one else, then potentially being back at work the second week is conceivable, okay? And then now, Angela asked the most important question. How urgent is surgery on a small, which is 1.1 centimeter by 0.9 centimeter benign parotid tumor? Angela, it all depends on two factors. What type of benign tumor you're talking about, and how fast this is growing. So let me turn this around for you, all right? So obviously, the speed of growth is very important. So let me show you, all right? So if your tumor in the past 2 months has grown from this to that, right? So if it started from here, 2 months ago was this size, and now it's this size, then obviously there's an urgency to do the surgery because this is a rapidly growing tumor. So that's important. But if your tumor was this size a year ago, and now it's this size, right? So it was 0.9 centimeter last year and 1.1 centimeter this year, the rate of growth is not high. That buys you time in a sense. The other thing that's important is the pathology, just like we were talking about. So there are, by the classification of the World Health Organization, there are numerous benign tumors that can occur in the parotid gland or in the salivary glands as a whole. And almost all of them have a very slow growth pattern. And outside of pleomorphic adenoma, the remainder, when they develop, stay benign. But pleomorphic adenoma, unfortunately, has a transformation rate that allows it to transform into a more aggressive cancer. So if this is a pleomorphic adenoma that we're talking about, and they biopsied it and they know it's a pleomorphic adenoma, then it can transform into, from this benign picture, it can transform into a cancer. So under the microscope, benign looks less involved. The dark dots here are the nucleus or the center of the cell. And then when you see a change, you see the center, the dark spots become bigger and so on. That's compared to this, and more of it, more obviously. Anyways, when it does happen, this transformation, it turns into an aggressive cancer. It has a poor prognosis. The 5-year survival is less than 40%, and 25% are already in the lymph nodes. And so it can be an aggressive tumor. But the risk of that transformation is 10% at 15 years. So 0.2% per year, you could say. So it all depends, again, on how long you've had it. So if the pathology is not pleomorphic adenoma, then the rate of growth is the only thing you're looking at, Angela, right? And if the rate of growth is slow, then I would say you have time. So if you came to me and said, I have Warthin's tumor, it hasn't been growing visibly, maybe 5-10% in the past year. I'm not having any pain or discomfort. My facial nerve is fully intact. Everything moves well. I'm not having numbness or tingling in this area. Then I would say you have time. You can take as much time as you need, really, if it's not growing rapidly, to do it. If, on the other hand, you came and you said that it is a Warthin's tumor, it is, since last year, it's doubled up in size, then I would say the larger it gets, the more involved it can get with the facial nerve, then you should do the surgery sooner rather than later, within a month, right? If you had a pleomorphic adenoma, on the other hand, and it has not grown, or maybe grown 5-10% over the past year, I would say if you're my sister, I usually tell my patients things like that because it makes more sense. If you were my sister, I'd say do the surgery within the next 3 to 6 months, right? especially if it hasn't been there for too long. So if you say this has been there for about 1.5 years, 2 years, and it hasn't really grown that much since I've discovered it, I'd say you have 3 to 6 months to operate, to take care of it. If you have pleomorphic adenoma, you've had it for 10, 15 years, and it is still growing very slowly, I'd say get on it sooner, because as time passes, the accumulation of toxins and things in the body that can cause a transformation into something more aggressive can happen, right? The more time you have, the more exposure to toxins in the environment, smog, whatever, hormones, preservatives in the food, whatever we're exposed to, the more likely it is for that transformation to happen. The reason these pleomorphic adenomas can become cancerous is that in order to get a pleomorphic adenoma, a few mutations have to happen. And these mutations are in line with mutations that can become cancerous. By that I mean, so if we say that a carcinoma, a cancer of the parotid gland requires, let's say, 7 mutations in the same cell, right? And if the pleomorphic adenomas already have 3 or 4 of those 7 mutations, then you're 4 out of 7 steps closer to this development of the cancer. And the longer you keep this tumor, the longer it's exposed to environmental toxins, the more likely it is that those mutations can occur, right? And so that's the idea. So all these matter. The pathology, how long it's been in place, how fast it's growing, what symptoms are you having, right? So the less time it's been there, the less growth it has. If the pathology is more favorable, not pleomorphic adenoma or something else, then the more time you have to address this, okay? One Haba is asking, pleomorphic adenoma size 2.5 centimeter. After surgery, I feel my face is more saggy. I look 10 years older. So that's an important question, because it has to do with how the surgery is done, right? If the surgery is done with a more extensive type of surgery, obviously more tissue is affected, and more likely it is for the results to be less consistent and look different from the two sides, right? And so the longer the incision, the more likely it is to have issues. The more further forward the tumor, the more the skin has to be peeled, and when it goes back down, the more likely it is to have issues. And if a reconstruction is done or not. So if there is no reconstruction done here, the skin may look a divot, like it is indented in, and may give a look that's not pleasing. So all those things are factors. The other thing is, sometimes when people are coming in and are having surgery and they're concerned about how the skin looks, if they have jowls, meaning they have a little lumpiness here, as we get older, all of us end up with that as the skin on our face kind of sags down and gets looser and gravity does its thing, you may get a kind of a bumpiness of the skin here. If that were to happen, usually you can combine doing a facelift surgery at the same time as a parotid surgery so that you can even out the face, tighten up a little bit. So those are possibilities. But what do you do now after the fact? I think at this point, if the skin looks more saggy, I would start by the less invasive, not a facelift procedure. I would start by seeing a dermatologist or a cosmetic surgeon and seeing if you can get lasers done to tighten up the skin, tighten up the collagen in the skin so that you can get more symmetry. The less invasive you are at the beginning, the better. But I would do it with someone who has experience so they can tell you realistically how much improvement you're going to get with a laser and so on, and go from there, okay? Let me get to another very interesting question that had come in a few days ago. Hello, I was hoping to ask a question regarding my recent MRI. A little history. I had a right parotidectomy for a myelofibroblastic proliferation. Right, so this is a benign growth. It's not a cancerous process, fortunately. Now with recurrent right ear pain, MRI says, the residual deep parotid lobe demonstrates normal signal intensity and enhancement without any abnormal enhancing soft tissue in the surgical bed. So no recurrence of mass or tumor that's visible. There is trace prominence of branching intraparotid ducts in the residual deep lobe gland near the upper limits of normal size, likely post-surgical. So it means that the ducts in the deep portion of the parotid are visible, right? Potentially, when they did the parotidectomy, if the ducts, some of them were cut as they removed the parotid, and those ducts that were cut scarred and closed down, then the saliva can't get through and it would back up and the ducts would dilate and stretch out and be more visible. That's possibly the issue. The doctor says that there were some intraparotid nodes seen deep in the gland, which could be causing ear pain. I'm worried sick about this and don't really understand what it means. Any help would be great. Let's flip the image and go to the picture. Right. So obviously the ear being around here. If a parotidectomy is done, right, and let me show you, an extensive parotidectomy was done, let's say. Right. So if an extensive parotidectomy is done and the superficial portion of the parotid, which is everything superficial to the nerve, is removed, and you have a small, and usually it's not this much parotid that's left behind when you do an extensive parotidectomy. It's usually just the parotid that's around the nerve, right? So it's only these portions that are left, right? And the rest is removed. So if that small portion is left, sensations in that small portions would be minimal because a lot of the nerves going to the parotid gland are cut as you're doing the surgery. And the pain that the person would experience would be underneath or around. So it would be around here. So underneath the ear or in front of the ear, further lower. They wouldn't be experiencing pain up there, right? And so if you are having pain in that area and you look at the MRI and there's nothing that looks actively inflamed or no masses that recurred, it's unlikely that the pain you're experiencing is coming from the residual of the parotid gland left behind. It's more likely that the pain is something inherent within the ear. So there are three things that cause pain in the ear. There are obviously infections in the ear, but I'm sure your doctor looked in your ear and can see that there is none. The joint of the jaw. So when I open my mouth, you see the jaw joint right here, opening and closing. So if because of stress or anxiety we clench in our sleep, the joint gets inflamed, right? And this joint getting inflamed, the first thing you would experience is actually pressure or pain inside the ear. In fact, if you put your finger in your ear and open and close your jaw, you'll feel the joint moving right in front of that ear canal. So you could clearly feel the pain in the ear if that joint was inflamed. And the last thing that causes ear pain is because the nerves to your throat come out of your brain, go through the skull in the ear, and then get to your throat. Any chronic inflammation, sore, canker sore, chronic tonsil infection, chronic salivary gland infection under the jaw, the submandibular gland infection, any of those things could masquerade as ear pain because the pain would go up the nerve and oftentimes people would experience it as ear pain. And so that could be the source of your problem. Please investigate those other potentials. That's it for the questions this week. It can be confusing dealing with parotid tumors because oftentimes the doctors just say, hey, you have a tumor, it needs to be removed, sometimes even without doing a biopsy, right? Which is how I was trained. I don't necessarily agree with that, but that's how I was trained. And I feel that a lot of times once patients have a small benign tumor that doesn't have the potential of becoming cancerous and it hasn't been growing in years and years, oftentimes you can actually sit and monitor these benign tumors, right? So if you have a less than 1 centimeter tumor and it's not a pleomorphic adenoma, so it doesn't have the potential of being cancerous, and the needle biopsy that was done got adequate amount of cells to be clearly telling you what the tumor is, and there is a classification system for doing needle biopsies on salivary gland. It's called the Milan system, and based on the Milan system, it can categorize the risk. It can tell you what is the chance of there being a cancer and what was drawn out in the needle. In any case, if the chance is low, the tumor is not growing, it's small, potentially you can monitor this thing, even with something as simple as an ultrasound, right? You don't necessarily need an MRI if you do an ultrasound and see it, so it can very easily be monitored. So for me, from my perspective, it's very important to get information and stay on top of that information. And if you go to a doctor and they immediately jump to surgery without explaining the reasoning for the surgery, then you may want to get a second opinion. This is an important area. You want someone with experience doing the surgery. You want someone with experience, more importantly, telling you if surgery is needed. And that is vitally important. I had a very bright, wise professor when I was in residency that would tell me that I can teach any monkey how to operate, but I can't teach them when to say no to doing a surgery. And that is, I think, even more important than knowing when to do a surgery. Because it's easy when someone comes in with a lump to say, hey, you need surgery, right? It is much harder and it requires more thinking to say, yes, because of these reasons, I think you don't necessarily need surgery, and monitoring is a better way to go. Okay, and creating the trust with the person and putting them at ease and explaining and treating people as if they are intelligent and can understand and make their own decision, which invariably they are and they can. Any case, that's it for this Q&A session. It's always wonderful to have the opportunity to answer people from all around the world. Hope you guys have a wonderful day, and I'll see you next month.